Okay, so hello everyone, and really thank you for the opportunity to present to you today with this fantastic panel of experts. And my name is Nirit Pilosof. I'm an architect, a researcher, and a consultant for healthcare architecture. And I've been working for a long time, over 20 years, on the topic of planning for change. Really, how can we design hospitals for future flexibility to support change? And one of the drivers, the main drivers of change, is technology. And in this presentation, I'm very excited to present an ongoing research on the implementation of telemedicine for inpatient care in ICU units at Sheba Medical Center in Israel. And I will present on behalf of Professor Michael Barrett from Cambridge University and Professor Ivora Born from Warwick University. And it's really a unique collaboration between the UK and Israel, both the Cambridge Judge Business School, the Cambridge Digital Innovation Center, the Center for Digital Build Britain, and the ARC Innovation Center at the Sheba City of Health. So Sheba Medical Center is the largest hospital in Israel, ranked as one of the top 10 hospitals in the world, is located in the outskirts of Tel Aviv. And since the outbreak of the pandemic, the hospital developed through its ARC Innovation Center new models of telemedicine, not only for outpatient care, as we saw all over the world, the great acceleration of telemedicine, but also for inpatient care. The main objective, as stated by the hospital management, was to protect the limited staff from contamination and lessen errors that are related to working in protective gear. The strategy was to increase the overall hospital capacity and provide the best medical treatment for the COVID-19 patient while continuing regular operation as usual. As most of the hospitals in Israel, Sheba rapidly utilized in only a few days an underground parking structure that was designed to serve as an emergency hospital for times of war. Here you can see the layout with almost 400 patient beds divided into different medical divisions, units. And they transformed it into a critical hospital care for COVID patients. And the logic behind this decision was the intent to isolate the coronavirus patients from the rest of the operating hospital units and to save money and time by utilizing an existing structure. The large side of the parking lot was divided into two ICUs with distinguished separation of clean zones and contaminated zones and controlled circulation routes. The two ICUs have an open ward layout of contaminated zones. You can see Ward A is colored in green and Ward B colored in purple. And both of them have a separate control room in the clean area, which you can see colored in yellow. The control room has telemedicine devices to remotely supervise, communicate, and control the operations of the unit. The units have different models. The control room in Ward A is adjacent to the unit with a big window. That was the photo that you saw right at the beginning of the presentation. And Ward B has no physical view of the unit. They only rely on telemedicine technologies. The staff was divided accordingly into two teams, one working in the contaminated zone with full PPE, while the other team supporting them from the control room, and they were all working in shifts of 12 hours and switching every 3 hours. So here you can see really an example how the layout was designed to support the new model of care of using telemedicine as a means to operate, communicate, and really care for the patients. The hospital employed different telemedicine technologies, and Israel is really known as the startup nation, chose to invest in medical technologies and innovation to cope with the challenges of COVID-19. The technologies for remote care supports monitoring, physical examination, management, and audio-visual communication, including video cameras and telepresence robots. Most of the technologies that were implemented at Sheba were not new. Some existed in models of electronic ICU, and others were used for special programs of the hospital to monitor home rehabilitation of patients. And not all of them were implemented in the ICU. In our study of the new model of inpatient telemedicine, we explore the intersection of architecture, technology, and healthcare. So this is really a multidisciplinary research. And by doing so, we really emphasize that the built environment has an impact on the implementation of digital innovation in healthcare services, something that is often not really taken into account, the impact of the built environment on the implementation of new technologies. And we focus on the shifting forms of visibility, a major theme in healthcare design that is transformed by telemedicine and physical materiality. While previous studies focus mainly on physical visibility or on virtual visibility only for communication with patients at home, we suggest to integrate the physical and virtual forms of visibility in inpatient care. We analyze the patterns of visibility that they provide, relationship between users, directors of view, focus, movement, distance, and angle, and examine their implication on the healthcare services, the management of the unit, teamwork and collaboration, and patient care. The research is based on semi-structured interviews of the hospital staff. We conducted over 30 interviews in only 2 months, and this was really significant. The staff was almost waiting for someone to come and ask for their experience. We did on-site observation and data collection of the hospital survey, technological briefs, webinars, and also documentaries on TV, because it was really, there was a lot of interest to know what's being developed in the hospitals. And the interviews and observations really reveal the impact of the shifting forms of visibility on the performance of the unit. For the management, many stated that they were missing an overall perception of the whole wide world that enables them to see everything entirely at every moment. The director explained, "When I make my evening rounds in the regular unit, I can see what is happening in all the rooms in a blink of an eye, as I take a 1.5-minute walk around the unit." The segregated view of the unit on screens does not provide a spatial perception of space, which was found to be crucial for orientation and a sense of control over the unit. It also is missing an integration of the audio-visual technologies and the monitoring systems. And mainly, they simply have a lot of screens to look at to operate the unit. To overcome this limitation of spatial perception, they actually had an innovation. Since they were already in a parking lot, they came with the idea to use a mini car, a closed club car, to drive through the patient's beds and have a better perception of the overall unit. And by using the car, the directors, they didn't have to put on the PPE because it was closed, but they had to drive through a special car washing machine to clean the car when they came out of the unit. The robot was defined by all the staff as the most efficient piece of equipment. The director explained that it provided them the option to move from place to place, to see more than one angle, to distance and focus, while the person on the other side can actually see the face of the person who was speaking to them. They described it as a game changer. The different layout of the wards had an impact on the implementation of telemedicine technologies. Each unit created different models for teamwork and collaboration. Obviously, the staff in Ward B without the window used the cameras and the robot much more than the staff in Ward A. The window was significant for visual communication of the staff, but the acoustic barrier led to low-tech solutions such as hand gestures and handwritten notes. The use of telemedicine technologies also transformed professional practices. For example, here you can see how the physician is using Untitled, which is a device to remotely examine the patient at home, actually at the bedside, because he cannot hear through the stethoscope covered with the PPE. So here the technology was used as a means to visualize the patient vitals. The new model of care also shifted the distinguished hierarchies of the staff in the medical unit. The head nurse explained to me that the PPE covered any characteristics of the professional role. When help was needed, any pair of free hands came to the rescue. It did not matter if it was a doctor or a nurse. Telemedicine was also used to prevent cross-infection by supervising the staff behavior, to make sure that they are changing their additional cover and gloves when moving from patient to patient. And this is really important to note that usually when the staff move from one patient to another in a regular ICU, they move from one room or one space to the next room, and they go through a space where they can wash their hands and change their outfit. So the built environment supports infection control. But here they only do 2 steps and they're right with the next patients. So really the cameras and the robot help to supervise their behavior. The conception of patient-centered care has changed. The physician stated the challenges of remote care, the frustration of not being able to place your hand on the patient when you give him bad news. But on the other hand, they state, I can be there for them even when I'm not physically present. There was also a lack of privacy for the patient, as the curtains were often removed because of the cameras. A resident doctor shared his concern. In this situation, the conscious patients witnessed the deterioration of other patients. They could see only a few meters from them what they are going to look like in another 3 to 4 days. It was a horrible experience for them. Loss of identity by the PPE was also very significant. And here I would like to share with you a short anecdote. One of the patients who was ventilated for an extended period of time and came to visit after he was sent home, after he was cured, came to visit the staff and to thank them for their care. And they asked him what he remembers from his experience in the ICU. And surprisingly, he said that the only thing that he remembers is the nurse on skates. And the team was really amazed, and they tried to understand what he was talking about. And the director explained to me that probably what he remembers is the robot. It's only the robot. And he explained that probably because all the other staff were people without faces, what he saw was people like aliens covered with masks. And the video on the robot screen was actually the only human face that he saw. And this is, in my opinion, really represent the shift in our conception of the relationship between human and technology. Family support was also a major issue with COVID. At the beginning, the hospital restricted visits of the unit and provided only virtual communication from home or from a special family center that they built especially for the families. But they soon realized that the families needed physical contact with their loved ones. And one of the directors shared his surprise when he recognized that this was also significant even for the ventilated patients. He stated, one patient shed a tear and the blood pressure and pulse of another went up when a family member came to visit them. The location of the COVID ICU in the underground site, with no visibility to the outdoors or daylight, had an impact on the well-being of the patients and the staff. One of the clinicians told me that it felt like working in a submarine. He stated, I think the staff developed PTSD and high level of burned out because of the underground location. It was caused by the place itself and by the general situation. You cannot separate the two. Another physician revealed that many patients who were not ventilated would beg him to be moved out. And really thinking of similar temporary emergency hospitals that were constructed in Israel and all over the world, without daylight or view to the outdoors, I cannot stop and wonder if they will not become permanent solution after so much money and resources were invested in them. And I really believe that when creating a high-tech environment, even if it's high-tech environment, the basic principle of evidence-based design to create a high-quality environment should not be compromised. So what can we learn from this study? I think it represents only a moment in time in the transformation of healthcare systems by advances in technology. Resilience was actually achieved by the implementation of digital technologies for remote care and the affordance of the built environment to support the change. It demonstrates a hybrid model of virtual and physical care, an integration that will probably continue to evolve in the future. The flexibility of the hospital to support change was crucial. Flexibility of the built environment, as well as the flexibility of the organization and the staff to adapt. We have to rely on evidence-based design to maintain quality of space, even in times of crisis. And we have an incredible opportunity and also a responsibility to transform hospital as part of the new healthcare ecosystem that integrates hospital care with community and home care by digital technologies. Thank you really for taking the time to hear about our ongoing research, and a special thanks to the ARC Innovation Center at Sheba Medical Center. Thank you.
Thank you so much, Nirit. Very interesting also to see how they were dealing with the non-daylight and so on. Do you know if there has been other follow-up studies on the built environment and how they dealt with the pandemic situation in your country?
Other research?
Yeah, or other studies?
Yeah, obviously, there is a lot of things that are being implemented right now, and they are all, I hope everything is being studied. There is, again, like I presented, there is an emphasis on innovation in technology, implementing really a lot of startups, a lot of innovation there. But I'm thinking about how should the healthcare industry, healthcare design industry, really have a say in this development? How can we really, drive the change? Because in many cases, the new technologies are looking at the built environment as a given or as a constraint, and we have to find ways to integrate the design process of both the technologies and the built environment. So I'm hoping there are more research in this field, but I have to admit that most of the research that I'm seeing is looking at the integration of the technology with the healthcare services, and not enough work is being done, as I mentioned, on the built environment, on the impact of the built environment and the flexibility of the space to really support the implementation of the technologies.
Thank you so much for your answer. I think we will now go to the poll questions. Thank you.